Thank you very much, Professor Sabri, for the kind introduction. First of all, I would like to thank Professor Salah Naga and Professor Ayman El Refai Do and the organizing committee of the prestigious NephroAlex. Do we still need corticosteroid for maintenance immunosuppression? I hope I can answer this question. For many years, corticosteroid was the cornerstone for immunosuppressive protocols in kidney transplantation. And although it's inexpensive, it's a cheap drug, however, steroids are associated with debilitated side effects, and treatment of these side effects add a lot of cost. In addition, such side effects increase the post-transplant non-compliance associated with increased incidence of acute rejection, chronic rejection, and graft loss. What's the rationale behind using steroid-free protocols? To get rid of all these unwanted side effects. Their negative impact on cardiovascular in the form of hypertension, diabetes, dyslipidemia, and other non-cardiovascular side effects. Moreover, these cardiovascular side effects are non-immune trigger of chronic allograft injury with negative impact on the graft survival. There are some concern about the implementation of steroid-free protocols. Mainly, what's the long-term outcome of steroid-free immunosuppression on the patient graft survival? If there is an increased risk of chronic allograft dysfunction, and are there real long-term metabolic benefits? Steroid-free started in 2000, and over the years there is increased incidence and evolution of many centers using this protocol. And according to this report from the US, there is increased instance of proportion, the increased proportion of patients who were discharged with steroid avoidance protocol. In 2009 was actually this year was the harvest of many studies about the steroid avoidance, and this is the 4-year patient and graft survival was comparable, both steroid-based and steroid-free. And in this year, the following question was addressed: steroid-free maintenance immunosuppression kidney transplantation. It's time to consider it a standard therapy. And the answer was from the KDIGO in the same year that we suggest that in patients with low immunologic risk and who receive induction therapy, corticosteroids could be discontinued during the first year after transplantation. However, in the literature, there is a dilemma about the safety and the efficacy of steroid-free. What is the reason of this dilemma? The reason that data from studies of steroid avoidance or minimization produce this conflicting regarding the harm versus the benefit, and the dilemma came from the heterogeneity of the studied population. Either the patient selection, some involved patients with low risk and high risk, there are heterogeneous group. The approach, we have steroid avoidance from start or steroid withdrawal, and what's the difference in the timing and type of steroid avoidance? And also the immunosuppression used was heterogeneous. No induction, weak induction, strong induction, and the maintenance. Is it cyclosporin or tacrolimus? So this heterogeneity make the dilemma. So the immunologic risk stratification is very important in tailoring minimization of immunosuppression in general in transplantation. What are the approaches of steroid avoidance protocols? We have two main categories, either steroid avoidance or withdrawal. For steroid avoidance, we may no steroid at all or just steroid for 1 week post-transplant. While in steroid withdrawal, we have early withdrawal, weeks to months, usually in the first 3 months after transplantation, and late withdrawal beyond the 6 months post-transplantation. What are the RCTs reported in steroid avoidance? This is the largest, actually, randomized controlled trial involved 40 international centers. They give all the patients basiliximab and they compared no steroid versus withdrawal after 7 days or standard protocol. What they get that the best was for the steroid based therapy for the proportion. This is the proportion of the acute rejection. The best was, of course, with the steroid. However, this was not significant when we compare versus no steroid or steroid withdrawal. But what's more important, that the mean GFR was comparable in the three groups. Now, what's the difference or the outcome between steroid avoidance and steroid withdrawal, either early or late? The harvest of all literature in this regard is that late steroid withdrawal after 6 months represent the least favorable method for steroid minimization, and acute rejection risk is clearly increased upon the late withdrawal of immunosuppression, just like the non-adherence, which happens in some patients. And it's apparent that certain steroid-related complication already happened after late withdrawal. So we lose the benefits of avoiding steroids. Again, the KDIGO supported this. If prednisolone is being used beyond the first week after transplantation, we suggest to continue rather than to withdraw. So steroid avoidance is better than withdrawal. The effect of long-term steroid withdrawal, this is the patient survival. There was a significant benefit in patient survival in the steroid avoidance protocols. We get rid from the diabetes, the cardiovascular, the stroke. So this was reflected on the patient survival. And this is a very recent article that was published 2 months ago, confirming that the steroid avoidance in immunological low-risk patients has a comparable safety and outcome like steroid-based therapy. We cannot implement steroid-free without induction. We should have induction. So those patients require the use of potent induction and selection of low immunologic risk. And attempt to use steroid avoidance regimen in the absence of induction is unaccepted. In this study, they compared the induction therapy. They addressed whether we need induction therapy or not and confirmed that induction therapy is mandatory. The impact of steroid maintenance on the outcome of the first-time diseased donor kidney transplant, this is analysis of the induction therapy. Actually, this was a huge number of patients, 27,000 patients. Patients who received ATG versus alemtuzumab and interleukin-2 receptor antagonist. And in each group, we have steroid and steroid-based and steroid avoidance. What we have got that the outcome was comparable in case of alemtuzumab and interleukin receptor blocker. However, steroid-free showed inferior graft survival with ATG. Likewise, this occurred in the patient survival. When we sub-analyze the patient who received ATG to see what's behind this phenomenon, we find that there was a mix between high-risk patients and low-risk patients. And when we separate the low-risk patient who received ATG, we get a comparable result, either in the patient survival or the graft survival. The maintenance therapy. We cannot use cyclosporin or Imuran for steroid-free. We should have potent CNI like tacrolimus and potent antiproliferative MMF. So we should have induction therapy, low-risk patients, low immunological risk patients, and MMF and tacrolimus. The other concern is the subacute rejection or subacute inflammation and the impact on chronic allograft injury. In this study, it shows clearly that acute rejection and borderline was comparable between steroid-free and steroid-based. And also, the degree of IFTA was comparable on the long term between the steroid-based and steroid-free. Now, what are the benefits and gains of steroid-free protocols? According to this intensive review by Professor Ahmed Halawa, we had a lot of benefits. Steroid-free protocol proved to be comparable with steroid-based maintenance therapy, and the appropriate approach should be tailored individually according to each patient, immunological risk, and the clinical situation. And by clinical situation, I mean this patient is obese, high risk of cardiovascular or diabetes. This is a pediatric patient, so we have to individualize the steroid-free regimen according to the clinical and immunological situation. This is the famous trial. Now we will start the benefits. The first benefit in the pediatric group. And this is a famous twist study. In this twist study, we showed that the patient, the proportion of acute rejection or the instance of acute rejection episode was comparable. And we have the gain that the absolute change in the mean height after 6 months was greater in patients who received steroid-free protocol. Not only on the gross, but the systolic blood pressure was significantly low in the steroid-free, the cholesterol, and with comparable GFR. So the conclusion of this large twist trial that the positive effect on growth in 6 months following early steroid withdrawal in pediatric transplantation, and this protocol has no detrimental effect on acute rejection patient graft survival, and both lipid and glucose metabolism profiles were significantly better. And this is a meta-analysis about implementation of steroid-free in the pediatric group. And the outcome or the conclusion of this meta-analysis that steroid avoidance regimen justified in the selected pediatric group because it provides significant benefit post-transplant. However, there is some criteria. Selected pediatric recipients should have the form prepubertal, low immunologic risk, and the primary disease should not related to immunological factor. And this is a very important point that I'm going to highlight, as patients with glomerulonephritis as original kidney disease is not suitable for steroid avoidance. Otherwise, the recurrence will be high, like in this report. We have significant incidence of recurrence for focal segmental, membranous, IgA, lupus. All these is not suitable for steroid avoidance protocol. The second gain in the cardiovascular side effects, cardiovascular morbidity, we have significant improvement in serum cholesterol, triglycerides, and hypertension. The estimated cumulative probability of developing cardiovascular disease is much significantly less in steroid-free protocols, and the estimated cumulative probability of patient survival was higher in the steroid-free regimens. This is the famous Sailor study, showed that the incidence of new onset diabetes after transplantation is decreased among the steroid-free protocol, and this regimen should be adopted especially beneficial for the patient who has high risk of diabetes, like family history, obese patient, age above 40. All these are risk factors for developing of BTDM. The stroke was significantly less in the patient with steroid avoidance regimens. The bone, the serum osteocalcine, like this study, was significantly higher among the patient with steroid-free, with comparable calculated GFR and mean serum creatinine. This is a very important report about the death with functioning graft. We know that the death with functioning graft is due to either cardiovascular, diabetes, infection, malignancy, etc. And in this study, they compared the different doses of steroids and the steroid-free. The lesser the dose of steroid, the lesser the death with functioning graft. And of course, the no steroids have the low instance of death with functioning graft. Death with functioning graft was significantly higher in the case of due to cardiovascular disease in steroid group, also for infection and malignancy. What about our experience in Mansoura with steroid-free protocol? We started our steroid-free protocol 18 years ago by this controlled randomized trial. We randomized 50 patients in 2 groups, all received basiliximab, and group with steroid and without steroid, and of course tacrolimus and MMF. And we reported after 3 years the outcome, and the outcome was very fruitful actually. We have the antihypertensive medication was less in the steroid-free. The mean body mass index was less. Gastritis, bone and joint infection, either bacterial or viral or fungal, and the instance of admission to the hospital was significantly less in the steroid-free protocol. What about the long term? Then we reported in 2015 the 12-year outcome. It was comparable, both patient survival and graft survival. Not only that, but we studied the cost benefit. We found that we have a cost benefit when we applying this steroid. The cost of what? The cost of treating all these diseases, the antihypertensives, the antidiabetics, treatment of gastritis, infections, antibiotics, antiviral, and the hospital infection. All these with showed significant cost benefits. Again, is it time to consider it as a steroid therapy? I can say yes. What we are doing in Mansoura since 15 years, that this is our protocol. We stratified our patients. If this is a low risk, we give them basiliximab, tacrolimus, and MMF. With a moderate risk, the same induction, but we add steroid. In the high risk, we use thymo as induction with triple immune suppression. My conclusion that steroid-free immune suppression should be considered as a standard of care for carefully selected group of patients. Immunological low risk, pediatrics, diabetics, and patients who have risk of to develop post-transplant diabetes, significant cardiovascular complication, obese patients who suffer from psychiatric condition or skeletal demineralization, and the success. These are the terms and conditions to apply this protocol. Proper patient selection, low immunological risk. You should use induction therapy, effective maintenance immunosuppression, and immunologic monitoring by DSA is preferred. I would like to end with this slide about the members of the nephrology and transplantation unit that I'm proud to be one of them. Thank you.